Differential diagnosis of wide complex tachycardia. Wide complex tachycardia WCTA rhythm with QRS duration greater than or equal to 120 ms and heart rate greater than 100 per minute. VT-WCT originating below the level of his bundle. SVT, at or above the level of his bundle. LBBB morphology, QRS complex duration greater than or equal to 120 ms with a predominantly negative terminal deflection in lead V1. RBBB morphology QRS complex duration greater than or equal to 120 ms with a predominant terminal deflection in V1. LBBB and RBBB morphology denote morphological appearance of QRS complex result from direct myocardial activation. Regular WCT, 1VT, MC cause of WCT in general population, 80%-95% of WCT in PTS with structural heart disease, 2 SVT with abnormal intraventricular conduction 15% to 20% of WCT, SVT with BBB/aberration, fixed/functional, Mohyam pathway-mediated tachycardia antidrama KVRT. Iota C, amiodarone, tricyclic antidepressants. 3 SVT with a wide complex due to abnormal muscle spread of impulse. RBBB in PTS undergone right ventriculotomy. LBBB in PTS with DCM. 4 SVT with wide complex due to drug or electrolyte-induced changes. Iota C, amiodarone, tricyclic antidepressants. Hyperkalemia. 5 ventricular paced rhythms. LBBB with left axis. 6 post-resuscitation. Irregular WCT. Any irregular supraventricular rhythm AF, EAT or atrial flutter with varying conduction, with aberrant ventricular conduction. AF with ventricular pre-excitation if the ventricular rate in AF is greater than 220 per minute or shortest RR int is less than 215 sec, bypass tract should be considered. Polymorphic VT, torsade de points. SVT versus VT history and physical examination. History of prior heart disease favor VT. Prior ME, angina or CCF. Each factor -95% ppv for VT. HO similar episodes for greater than 3 years, SVT more likely. First episode of WCT after ME, VT more likely. Older age GRP greater than 35 years VT more likely, findings of avenue dissociation, favor VT. Canona waves. Variable intensity of S1. Variable SBP. Avenue dissociation can be brought out by carotid sinus massage, adenosine. Termination in response to CSM, adenosine, Valsalva suggest SVT. ECG features. QRS morphology. SVT with aberrancy QRS complex must be compatible with some form of BBB or FB. If not, diagnosis by default is VT. Specific QRS morphologies. V1 with RBBB. SVT with aberration. Initial portion of QRS not affected by RBBB aberration. Triphasic complex, rabbit-ear sign, with right peak taller. RSR, R septal activation, S activation of LV, R activation of RV. Pattern SOVT. Monophasic R. Broad greater than 30 ms initial R. QR. Triphasic complex with LT. Peak taller. V6 with RBBB. SVT with aberration. QRs, Rs, RSR/S greater than 1. Delayed RV activation produces a small S wave in V6. Pattern SOVT. RS, QS, QRS, QR. RS with R/S less than 1. Large S due to RV component of ventricular activation plus depolarization of some portion of LV as activation propagates away from V6. V1 LBBB. SVT with aberrancy. RS, QS. Rapid initial forces narrow R and rapid smooth descent to nadir of S. Initial forces are relatively preserved. VT. Broad R/deep S. QS with a slow descent to S wave nadir. Initial R greater than 30 ms SOVT, wider the R, greater the likelihood. Notch in downstroke of S. Interval from onset of QRS to nadir of S greater than 60 ms. Taller R during WCT than sinus rhythm. V6 LBBB. SVT with aberrancy. Lacks initial Q wave. Monophasic R or RR. VT. QR, QS, QRS, RR. Patterns consistent with SVT may be seen. Width of the QRS. Site of origin. Lateral free wall of the ventricle very wide QRS. Close to the IVS smaller QRS. When during tachycardia, the QRS is more narrow than during sinus rhythm, VT should be diagnosed. Other factors that play a role in the QRS width. Scar tissue, athermy. Ventricular hypertrophy. Muscular disarray, as in HCM. QRS complex duration. VT probable when QRS duration greater than 140 ms with RBBB morphology, greater than 160 ms with LBBB morphology. QRS duration greater than 160 ms a strong predictor of VT regardless of bundle branch block morphology. QRS duration less than 140 ms does not exclude VT. If the tachycardia originates in the proximal part of the His-Purkinje system, duration can be relatively short, as in fascicular VT, where QRS duration ranges from 0.11 s to 0.14 s. QRS axis. Identify site of origin of VT and etiology. VT from apical part of the ventricle superior axis. VT from basal area of the ventricle inferior axis. The presence of a superior axis in patients with RBBB-shaped QRS very strongly suggests VT. The presence of an inferior axis in LBBB-shaped QRS tachycardia or VT. Extreme axis deviation, -30 to -180, suggest VT. QRS axis. Mean QRS axis in the normal range favors SVT with aberrancy. Right superior axis -90 to ±180 degrees suggests VT. Axis shift during WCT of greater than 40 degrees favors VT. LBBB morphology with RAD, almost always due to VT. RBBB with a normal axis, uncommon in VT, concordant pattern. Concordant precordial wave progression, high specificity for VT, 90%. Low sensitivity observed in only 20% of VTs. Negative concordance, apical VT. Positive concordance, ventricular activation begins left posteriorly, seen in VT originating in Lieutenant post wall or SVT using a left posterior accessory pathway for avenue conduction. Concordance of the limb leads, predominantly negative QRS complex in limb leads SOVT. Avenue dissociation. Most useful ECG feature. Complete avenue dissociation seen in 20 to 50% of VT, sensitivity 20 to 50%, specificity 100%. 15 to 20% of VT has second-degree VA block. Variation in QRS complex altitude during WCT, due to summation of P wave on the QRS complex clue to presence of AVD. 30% of VT has 1-to-1 retrograde conduction, CSP or adenosine used to block retrograde conduction to diagnose VT. When the atrial rate less than ventricular rate, SOVT. Atrial rate greater than ventricular rate, SOSVT with conduction block, evidences of avenue dissociation. Fusion beat, when one impulse originating from the ventricle and a second supraventricular impulse simultaneously activate the ventricular myocardium. Morphology intermediate BW sinus beat and pure ventricular complex. Rarely in SVTs with aberration. PVCs can produce fusion beats. Capture beat, normal conduction momentarily captured control of ventricular activation from the VT focus. Onset of tachycardia. Episode initiated by a premature P wave, SVT. If it begins with a QRS, can be ventricular or supraventricular. Presence of Q waves during a WCT, SO-OLD-ME, SOVT. Patients with post-ME VT maintain Q wave in the same territory as in NR. DCM Q waves during VT, which was not there in sinus rhythm. Pseudo-Q retrograde P deforming the onset of QRS. QRS complex during WCT narrower than NR. In presence of BBB during NR, a WCT with a narrower complex indicate VT. Contralateral BBB in NR and in WCT SOVT. QRS alternans. Alternate beat variation in QRS amplitude greater than 0.1 mV. Occurs with equal frequency in WCT due to VT and SVT, but greater no. Of lead show this, 7 versus 4, in SVT with aberrancy. Kramer et al., AJC. Multiple WCT configurations. More than one QRS configuration during a WCT VT more likely. 51% of PTS with VT, 8% with SVT in one series. Importance of sinus rhythm ECG. Differentiation between VT and SVT with antegrade conduction over accessory pathway. Aberrancy, rate-related or pre-existing. Presence of premature complexes in sinus rhythm. (OLD-ME, pre-excitation. QT interval. ECG clues to any other structural heart disease. Rule out ECG artifacts which may be misdiagnosed as WCT, VT versus pre-excited tachycardia. Predominantly negative QRS complexes in V4-V6. Presence of a QR complex in one or more leads V2-V6. More QRS complex than P. 75% sensitivity and 100% specificity for VT. Steyer et al., criteria for diagnosis VT versus SVT with aberrancy. Griffith et al., 1991. QRS morphology in V1 and AVF, change in QRS axis greater than 40 from normal rhythm and HOME. Predictive accuracy greater than 90% in detecting VT. Kramer et al., 1988. Recordial concordance, NW axis, monophasic R in lead V1. Brugada criteria. Brugada et al. Analyzed 554 cases of WC tachycardias with a new algorithm. Circulation 1991. Sensitivity of the 4 consecutive steps was 98.7% and specificity was 96.5%. 4 criteria for VT sequentially evaluated. If any, satisfied diagnosis of VT made. If none are fulfilled, SVT. Evaluation of RS complexes. Measurement of RS interval. New AVR algorithm. Veretsky et al., Heart Rhythm 2008. 483 WCT, 351 VT, 112 SVT, 20 pre-excited tachycardia, analyzed. Greater sensitivity for VT diagnosis than Brugada algorithm, 96.5% versus 89.2%, p.001. Greater specificity for diagnosing SVT compared with Brugada criteria. Reasons for using AVR. During SVT with aberrancy, initial septal activation and main ventricular activation are directed away from lead AVR negative QRS complex. Exception: inferior ME initial R wave, RS complex, during NSR or SVT. Initial dominant R suggest VT typically originating from inferior or apical region. SVT with aberrancy initial activation is rapid. VT initial ventricular activation slow due to muscle-to-muscle spread of activation. Vi/Vermont, ventricular activation velocity ratio. Vi initial ventricular activation velocity. Vermont terminal ventricular activation velocity. Both measured by the excursion, in MV, ECG during initial, Vi, and terminal, Vermont, 40 ms of QRS complex. Thank you.